Hello, everybody. Welcome to another edition of AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And joined today by also Rescue 11 Lieutenant Tiffany Johnson.
Hi, how are you?
Thank you for joining us again today. Okay, so another interesting case out of Station 11. And this was unique because you had made a swap that cycle so you could jump on the engine. So
I did.
Engine 11 and Rescue 11, and you all were dispatched to an unconscious pediatric patient, 31 Delta. I always ask this, but as far as like information that you were able to get from dispatch on what exactly you were going to, any additional information, and what's going through your head as you're going to that call?
Right. So now that we have Siri, we don't really get the age of patients anymore. We just get that this was a 31 Delta. And so when we got to the MDT, I noticed that it was, because I like to scroll to see what we're going to. So I noticed it was a 1-year-old male, and there was no information after that that I can recall. It just the simple pro-QA questioning that he was, he was conscious, that he was breathing, and that's what we had.
Perfect.
So.
Captain Luciani and his team in the alarm would be so happy to hear you say that you scroll to check those notes, because I know they're vigilant about getting those notes in there because of the mock alert system doesn't really give us much more information than the coding itself. So great job on that. So you have the 1-year-old, you arrive on scene. Tell us what you saw when you first got there.
Right. So the rescue had actually shown up a little bit before us. So we were walking in as the second unit. I had, if I'm going to name drop, I had Chris Northup and Marcus Dowdikin on the rescue that day. So that's a rogue rescue for us at Station 11 that day. So they had gone in and they had already started somewhat of an assessment of this little boy. So when I walked in, this little boy was sitting on the couch, and he had this massive tortilla in his hand, and he was sitting upright, but you could tell he was somewhat lethargic, and he would do this, what I would consider, if he was an adult, somewhat of like a head nod, kind of like we call it the narc nod in our district, but he was definitely nodding off. But the minute that his head would hit sort of bottom, right, to a full extension of his neck, he would cry out in pain, and he would be so fussy and he would be so upset. But then he would start to kind of chew on this tortilla again, and it would almost console him to then he would go back to this sort of unresponsive status. So in my opinion, he was a painful stimulus at that point. So that's what I saw just looking at him. His skin color was great. He was pink. He was dry. He didn't look like he was unkept. And just that was my initial assessment. His airway seemed to be obviously outside of this tortilla in his mouth, seemed to be patent and maintained. He cried very loudly. I didn't perceive him to have any kind of respiratory distress. And like I said, his skin was great. So
interesting. And unfortunately, we've seen it more often recently of kids getting into parents' medications, finding illicit drugs. So that's typically the first thing we're going to think of when a 1-year-old who's normally, up and responsive and being a 1-year-old is kind of lethargic.
Yeah, my red flags were all over the place in this apartment. And every thought that I could possibly have in terms of why this ped was acting the way it was came into my head. This is that paramedic critical thinking that tends to flood your brain when you're met with these kinds of things. I went I went back to the BLS acronym of, reasons for people being unresponsive, right? And this pertains to kids too. So I started looking around for those AEIOU tips, to be honest with you. I was looking for signs of alcohol, and in this house, there were a lot of empty beer bottles, and they were all within reach of this child. I looked for paraphernalia. This individual, this caregiver, had a marijuana bong sitting on this table within this kid's reach. I even asked the caregiver, do you have any things that, in terms of drugs, marijuana, that he could have possibly gone into? And he had pulled out kind of a green bag full of edibles that were even more within reach of this little kid. So I was looking for things like that. I had asked if he had any kind of medical problems. I was investigating, the birth to determine whether or not there was any kind of congenital defects or if there was a complication with the birth, or, even to the extent of maybe he had some sort of, brain abnormality, heart abnormality. I was thinking about all that kind of stuff. So I was thinking, okay, does he have seizures? Is this a postictal state from a seizure? A lot of times infants aren't necessarily diabetics right off the bat, and, sometimes it takes incidences in young age to determine that, hey, your child has a new onset of juvenile diabetes. And so that was one thing that we took in consideration too, was taking his blood sugar. But I asked, does he fall often? He's got a big old noggin. Does he fall? Yes, he falls a lot. In terms of the eye, I was thinking infection. Has he been sick recently? This caregiver really denied the sickness of this child. But it was weird to me because scanning this house, I noticed that on the table there was a bottle of children's Tylenol and then a bottle of little nasal spray. So I know that this kid's been sick recently. How recent, I don't know, but that cued me in. So then that made me want to take a temperature, kind of rule out not only recent illness, but then with the head bobbing, I'm thinking this kid may have meningitis. We have an altered mental status, possibility of a fever. That's a key sign. That neck stiffness, it's a key sign of possible meningitis. So I was thinking that. I saw an empty bottle of escitalopram, so Lexapro, on the ground. I had asked about that. Could he have possibly gotten into this? And I was just met with, everything of no. So it was really hard to believe the caregiver on scene as being a good historian in terms of this patient, especially because he was doing a lot of reverting to the child's mother for answers too. But I will let you know, my ears were very perked with this scene. My flags were definitely red. So that's what I noticed about that scene.
That's interesting. Red flags all over that apartment, basically. So yeah, that's wild. So I guess ultimately what we can do as providers is we take all of that into account, right? Help make our decision as what we think it could be, but ultimately it comes down to our physical assessment, vital signs, and findings.
Right.
So talk with us about what you found when you started that assessment of the patient in terms of vital signs.
Sure. Obviously his LOC, so I call them bullet wounds. So anything that's a problem, it's as apparent as like a bullet wound. So when obviously his LOC was a bullet wound to me that I wanted to kind of figure out why he was unresponsive. So obviously running through all of those AIU tips, I was asking questions, finding history. That's how I was trying to close that bullet wound. As we moved forward, we did notice, I wanted that temperature taken to rule out recent illness, any kind of fever. And kind of just do more of an assessment there. He didn't have a fever. I believe he was afebrile in the 97 degrees range. We obviously checked his heart rate. We checked his blood pressure. The first blood pressure came back kind of weird. I believe like his diastolic was somewhat lower than what I would expect to see, but his systolic was higher than what would expect to see for a 1-year-old. So we definitely recycled that, got a more appropriate blood pressure. So I didn't perceive him to be hypovolemic in any way, shape, or form. Had asked about, his intake, his output, etc. We determined we felt his fontanelles to see if we had any kind of depression or bulging of his fontanelles. Just kind of moving down in terms of his vital signs, his lung sounds were clear. We were checking to see if he had any kind of abnormal lung sounds. And then we took a sugar. His sugar was in the 30s. So that's obviously another bullet wound to me, but that doesn't stop my progression. So I kept moving down. I wanted to feel responsiveness because at this time, my concern was his airway, in this tortilla in his airway. So I actually removed the tortilla from his airway and got him kind of laying down in a more stable state so that he wasn't bobbing his head and having that painful reaction as he would bob his head. I did feel down the back of his head to see if there's any trauma. I looked all over his head to see if he had any trauma. I looked at he was in a diaper, so we could see just what his normal body looked like. So I didn't notice any bruising in any kind of different stages or things like that. So in terms of physical abuse, I didn't see any whatsoever, and he was in a clean diaper. So obviously he was well kept in that regard. So when we moved into the BGL, that's when we decided, it's going to be a good idea drop some D10. With this little guy, when we laid him down, he became more unresponsive, which I kind of expected. And so starting an IV on him, trying to get an IO on him was kind of where we were going. We did have an attempt that was made that was missed, and then I used a 24 in his hand to be able to establish that that IV in his hand. My main concern, obviously, with giving any kind of dextrose, just even in D10, is that it can be very necrotic in nature, can cause a lot of vascular issues if we don't hit it appropriately. And so I really wanted to make sure that that line was good and patent before I just gave him this, super thick, like viscous sugar that could potentially, have some sort of secondary reaction to it. And then it was, I went to the protocol. Peds are very, kind of up and down. This is a reason why we have Broslow tapes, and we have the sort of dose now for like our arrest patients. But I went straight to the protocol to determine how much to give for this patient. It was a quick, effective pull-up dextrose. It gave me the nice Broslow colors. And I said, cool, he's approximately 40 pounds, so I put him at 19 kilograms. And I cheated. I stole the numbers off of the protocol. And I believe I gave him 105 cc's of fluid, which was 10.5 grams of our dextrose. So, and I ran it through a Buretrol, which this was actually the first time that my crew actually was able to see a Buretrol in its true form, not just in a practice kind of situation. I mean, I've pulled Buretrols out and we've talked about them at the station, but this was actually in action that they got to see it. And so being able to kind of have a teaching moment on that scene, like, all right, this is the reason why we talk about this, because this is the perfect situation and why we need to regulate the fluids and certain medications on these peds. And so kind of walked them through as I did the Buretrol, filled up the Buretrol to what I needed it to be. And we started giving this baby that D10. So we decided at that point to then just initiate transport. So we had plugged all the visible bullet wounds that we could see, and we figured definitive care was a little bit more appropriate. So one more thing, I also considered like a Brewy with this guy, because I didn't know initially how long he had been acting this way. So having an understanding of a little bit more of what his story was important. Obviously Brewy, brief, unexplained, resolved, unexplained event, right? So, but this wasn't brief. Apparently that he had been acting altered since this morning, and I believe we responded to him early afternoon in like the 1 o'clock time. So this wasn't like he did this for 15 minutes, he held his breath and turned blue, and now he's fine kind of situation. This was a long-standing altered mental status kind of situation.
Interesting. So we administered the D10 via the Buretrol. We're en route at this point. Did we see a response to that?
So we actually turned him over to 5.5. So we didn't ride in with this patient. When we moved him into his car seat, he did not have an additional response. So that cued me into putting him on a 4 lead. So we at least put him on a 4 lead. I was checking his pupils to see if there's any changes in his pupils to kind of rule out possible like head injury as to why he's now suddenly unresponsive. We did recheck his blood sugar. I think we were up in the 70s, but it didn't change his level of response. So now I can't speak, obviously, what happened after we closed those doors. But that was kind of when we got him into the back, it was at least a 4 lead, and let's do a little bit more of an evaluation to rule out some of those red flags,
Great job. How prevalent is this? We don't see it very often. We talked about this case being unique in that we deal with diabetic patients pretty regularly, but it's not often that we get pediatric hypoglycemic patients. How often do you see that on the ED side?
It's very rare. I was telling Tiffany earlier, this is the first time I think in my 5 years as medical director that we've had to give IV dextrose to a pediatric patient. And even in the ED where I work, I think it's a fairly rare occurrence. And in general, the kids that I've had experience giving it to the most tend to have an underlying metabolic disorder. it tends to be kind of a known problem for that child and not just kind of out of the blue. Right. So this one, you wonder what he got into. The next thing with an unexplained hypoglycemia is typically, okay, what else, what kind of toxin or medication is on board that's causing this to drop?
And that was my thought process too, was kind of along the lines of, I know the historian wasn't great, but there was a lot of red flags of things around there. Could it have still been something where it wasn't, metabolic on his side, where he got into something and it really affected that sugar?
Absolutely. That would be my next thing. And then the third thing, so in addition to underlying metabolic disorder, some sort of ingestion, would be infection. So I think everything that you had going through your head was absolutely appropriate. And then as you find critical issues, just address those as you go and see where you can get.
And Doc, we talk about this regularly, but and LT talked about it too, about the non-accidental trauma and trying to rule that out. They did a good head to toe to make sure nothing with, as far as the respiratory drive, the pupils, anything was thinking that we would administer Narcan. But why are those tools in the toolbox that we have to think through now in the pediatric population?
So this, as we talked about, is a pretty rare case, which is why we're talking about it. But a lot lately, we've been seeing a lot of children that are altered, that aren't breathing efficiently and have gotten into actually a different kind of toxin and narcotic, the blue fentanyl pills in particular, where we're encouraging folks to give Narcan for that. So there's a lot of dangerous things in pediatric environments, and especially our children that can't speak yet. They explore the world, with their hands and their mouth, and everything that they touch ends up in their mouth, and they can get even just a little bit of residue can really cause a lot of problems. And so doing a thorough exam, looking at their skin everywhere, behind the ears, under the tongue,
everywhere,
under the diaper,
and
then getting a full set of vital signs to help kind of guide what you need to do.
And do we have law enforcement on scene for the time that we were there?
No, the scene was pretty, we kind of wrapped it up pretty efficiently. The caregiver in itself seemed, I didn't get very many red flags from him. I was getting it more from the scene. And to me, it just looked like a little bit of inattentiveness to the child being there. And I didn't ask the status of the relationship with the mother. I know the mother he had called the mother to then ask questions that I would perceive that, a family member of this individual should know. So that was one thing that kind of just was a little bit more heightened with me, was that there was a lot of unknown for this patient that was claimed to be his son. So that was where my thoughts were at. And then my thoughts were, well, if I can separate this baby from this potential environment, then it's going to be better for him than what we're dealing with now. So I don't know in terms of living conditions if this is a temporary stay sort of situation, or if this was something where he's over here all the time. This is his normal environment. And if that's the case, then it would have been more of I think we should maybe do more of a CPS kind of investigation sort of thing. But to me, it seemed like a more temporary than permanent situation, just in terms of what I saw in that house. It didn't seem like a 1-year-old would stay there very frequently, if you know what I mean.
Yeah, and I think we always talk about the treatment and the transport of the patient. They take priority. So we're obviously, even if those red flags are there and the patient has high acuity, we're not going to wait for law enforcement to arrive. But and I know we didn't get follow-up on this specific patient, and we didn't execute the transport, but if you could just talk through quickly as far as for our newer providers, if they were to transport this kid, what's some information that they should relay to the hospital to kind of share those concerns?
I think some of those red flags that I saw on scene are important. I think that the more involved that we can get the ER staff in terms of knowing what we saw, I think it's really important. I think, unfortunately, they only get so much of a view. It's just we don't get much of a view of what happened before we show up. So to give them an idea of what happened as we were working through that scene and kind of what we saw, and being very, very in depth about it and voicing our concerns. I think the big thing is to voice those concerns. You know, we're mandatory reporters, so anytime that we experience things that potentially could have a child, you know, some of our elderly population, anything that happens to be to kind of cue those hairs on the back of your head up, I think it's worth documenting to its completeness, and then letting other people know about it. With him, if I had been the transporting unit on this call, I absolutely would have brought up the scene. I would have mentioned the bottles. I would have mentioned the empty pill bottle. I would have mentioned the paraphernalia. I would have mentioned the fact that I even saw medications that indicated illness, but it was denied. You know, I would have mentioned all of these things, kind of a little bit of, you know, lack of knowledge from the caregiver in terms of appropriate developmental age behavior. You know, this is a 1-year-old, and, you know, I don't know too much about 1-year-olds. I have one, but I don't think it's appropriate to be feeding a 1-year-old a tortilla, you know. So airways are very, very small in these populations, and so to have that as opposing threat, that was a red flag to me. So a little bit of some uneducation from this caregiver, I think it's important to bring up to that staff. And then that way they can follow through and do a little bit more investigation in terms of this patient versus just specifically treating the medical problem. I want them to do a big picture view of this baby and say, all right, you know, it's not just this hypoglycemic event. Like, this is now possibly, you know, we might want to bring CPS into this. And, you know, like on the positive, like hopefully it's just, you know, a parent needs a little bit more education for a first-time parent, and they walk away okay. But, you know, if this is what saves that child from a potentially, you know, excuse my language, but damning situation, then I'll shout it from the rooftops. I mean, I think it's really important to voice.
Absolutely. I think being the voice for the vulnerable populations that you've talked about before, pediatric, geriatric patients who don't have that voice for themselves often, that we have to do that. So great job.
Right.
I appreciate that. That is it for today. Thank you again for coming to talk through this interesting case. If you have any more cases you'd like to share, go through our SharePoint page or reach out to anybody from the EMS division. We're really trying to recruit more folks to come out and talk about the great calls and the great care that you provide. So reach out to us, let us know. Until then, we'll see you next time. Thanks.